Okay. All right. So yeah, thank you. If you turn on your video, it really helps us get viewership, and since it's free, we like to encourage people to just help us out in that way, or like, comment, and subscribe to the YouTube channel really helps as well. So just a quick blurb about what we are and how we work is I'm here promoting a medical education video game that I'm making, and but I'm also here, and if we make $1 billion, I'm still going to be here teaching. I like teaching. I enjoy it. I want to help people do well in the exam, and so you know, if we get more people, I'll do more sessions a week, and so that's another aspect to this. If you want private tutoring, we also offer that. We also offer group tutoring for a greatly reduced price, because we could even record those and put them on the YouTube video as well. So just really appreciate you guys coming in, and hope you guys get something out of it. So we've been doing lectures in the beginning to allow people to kind of have some time to join us. So I'm going to get started here with that by creating a new whiteboard. So the really quick blurb is, this is actually not one of my mnemonics. This is just something that's too good to exclude from the things that I mentioned. So are you guys familiar with kind of adrenal insufficiency, like congenital adrenal insufficiencies? Have you guys come across those questions? I feel like those are kind of like what I call like a kernel of knowledge, where they just expect you to understand the pathophysiology of kind of the implications of having insufficiency adrenally. And they want you to understand that there are 3 types, and they want you to understand genetically what is going on and which enzymes are affected in the adrenal cortex. And there are 3 layers of the adrenal cortex, and the mnemonic, it's not really a mnemonic, it's just the order of the layers is GFR. But people say, you know how people say, maybe you don't, it's kind of an American term for rock and roll, but they say sex, drugs, and rock and roll. There's also a mnemonic for this, which is like sweet, salt, sweet, and sex. So that's SSS, right? So that's because the glomerulus, which has certain histology that is similar to the glomeruli outside of the adrenal cortex, is going to be producing things that increase your blood pressure with salt, namely sodium increases in your serum, and the retaining that sodium is going to increase your blood pressure, right? And then the F is going to increase your sugar. It's going to be like cortisol in its action. And then the reticulum is going to be, the R is going to be kind of increasing androgens, which they don't just, it's not sex really, it's really increases in male sexual characteristics. So those are the layers of the adrenal cortex. Physically, literally, those are the layers of the cortex, meaning this is the thin layer on the external part of the adrenal gland. Then on the inside of the gland is something called the adrenal medulla, which produces epinephrine, norepinephrine. And those things raise your blood pressure and increase your heart rate and contractility and do all sorts of things. So we're talking about the cortex when we're talking about adrenal insufficiency. I'm not going to do a whole lecture on adrenal insufficiency. I'm just going to kind of really quickly run through this amazing mnemonic. I think it's like one of the most succinct and easily encapsulated subjects on the basis of this one mnemonic. I don't remember who to credit for this, and I'll put it in the description if you guys give me that information. I'll even mention it aloud if you guys Google it or use OpenAI. You'd get way ahead of me. But Chat GPT, but it goes something like this. So you guys know the numbers, the three numbers. I'm just going to call on people at random instead of doing attendance. It occurs to me that I can just ask people at random. If I'll just assume that they're not here yet. But Fatima, you just joined us. Are you here? Fatima, are you here yet? Can you hear me? Here, I'm just gonna put you. I'm just gonna put you in the waiting room for a moment. You're more than welcome to join again. I just want to organize people so I don't call on them for questions. AJ, are you here? AJ, can you hear me? All right, same deal. You're more than welcome to listen and engage with us. But the one requirement we have is that you're prepared to answer questions if we do get to the point where we're just calling you out. I'm not calling you out. I want you to learn. So, but I'm on deep. Are you here? Can you hear me?
Hello, I'm here.
Oh, great. All right. Welcome. So where are you coming from? I'm just curious.
I'm from New Delhi, India.
New Delhi. Okay, I've been there. All right. Well, welcome. I'll just ask you a quick, like, do you have you studied adrenal insufficiency at all?
Yes, yes, I have studied it.
Okay. So what kind of are the names of like the numbers involved with the three names of the kind of types of congenital adrenal insufficiency?
117 hydroxy, I guess something like that. One is related to 11.
Yeah. And do you know the third one?
Hydroxylation. 3 beta hydroxylation.
Yeah, you're doing great. These are the correct names, hydroxylase. So
21
hydroxylase
alpha
is the
hydro 21 alpha hydroxylase.
yes, exactly. And so I know
11
you know it.
alpha.
I call people on the spot and they forget everything they know, and I totally understand that because as a student, that's what I do. Um, but you do know the answer, I can tell.
Yeah.
I'm bringing AJ and Fatima back. We'll see if they're coming back to us. So one thing to notice about these numbers is they all have ones in them, so that helps you remember them. But I'm not going to be able to help you remember exactly what they are, what those numbers are, and the test will usually remind you. So 21 alpha hydroxylase is the most common. So that's one thing to keep in mind. If you have to guess, I would guess that one. But but this is a really beautiful mnemonic. So the way that you do it is you put hypertension. All you're thinking about is the glomerulus layer and the reticulum layer. So this layer and this layer. You can leave this one out for now because we're thinking about androgens. Because clinically, we're thinking about androgens, and we're thinking about blood pressure, so like hypertension. And so I would like take a picture of this and remember this forever because it's just really beautiful. So if you write 21 here and you write 17, right, um, and 11. So we're going to call all of these numbers that happen to be ones. We're going to call them up arrows. Okay. And this is exactly clinically how it is distributed. So I'm going to give you one example, and then I'm going to ask the next person what you would expect. Thank you, Amandeep, for helping us out. Bushan, for 21 alpha hydroxylase, do you know what the clinical picture is likely to show on the USMLE exam anyway?
Hello, can you hear me?
Yes. Welcome. So can did you sometimes the connection's not on, but so what are the what's like the clinical picture in terms of hypertension and hyperandrogenism do you see with 21 alpha hydroxylase deficiency?
Uh, there will be hypotension and virilization.
There be there be hypotension and hyperandrogenism. You're saying?
Yeah.
Yeah, exactly. So so what you do
So
is you think about this arrow. I mean, in addition to knowing it, which you may already know the pathway. You know, the 17 is going to help you go this way, and the androgens, you know, on that diagram that shows the androgens being over here, and the aldosterone, you know, similar enzymes being over here. 21 is going to help you move down, and 11 is going to help you move down further on this chart that you guys may have come in contact with occasion. I have an
also,
example.
also one more thing I noticed was whenever there is hypertension, you will get hypokalemia and vice versa.
Yeah, yeah, yeah. So I have a video playing that. We can use that. Okay. Um, so absolutely, yeah. So that's great. Those are like really good observations to have, and if you understand the physiology, it may not be necessary to even use this mnemonic. But in the meantime, for getting questions right, and even it's even good to memorize things like this that are really kind of stupid and simple before going into the physiology and even afterwards, just to check yourself and just have a disparate form of knowledge such that you can say, I know this pathophysiology, I figured it out, I have the up arrows, I have the down arrows, but what I want to do is cross reference it to something else that I know so that I am safe, you know, so I'm not making clerical errors. And so if this one is on the right, it's going to increase androgenism. So this wasn't increasing hypertension, which is to say that the enzymes, the hormones that would be produced as a consequence um, of of you know the pathway are being cut off, and you're not producing those hypertension, you know, the things that are regulating your blood pressure and increasing your blood pressure, like aldosterone. And so you're going to have a deficiency there. You're going to have hypotension. So Bouchon's like exactly right. You know, cortisol also increases your blood pressure, but it also acts on glucose, and it's very similar in its presentation clinically to increasing your hypertension. So we're kind of neglecting to talk about that. But you might also see you know, you might also see some you know, glucose in the blood increases in from the normal range. So if I would thank you, Bouchon. So I have somebody whose name is a period. Could I ask you? Can I talk to you for a second? Usually, I at least ask for a first name so I can call you something. Because otherwise, I'm just calling you, you know, by punctuation. But I'm gonna put you in the waiting room just for a second, not to you know put you in the corner or anything. I just want to call on people who are going to be here so that I'm not wasting anybody else's time talking. Um, so, Candace, are you here?
Yes.
Okay, welcome. Where are you coming from, Candace? I'm just curious.
Houston, Texas.
Oh wow. Okay. Awesome. Awesome. Well, I've been there. I love that city. I like the airport because they have the what is that seafood restaurant? It starts with a P. It's a New Orleans style restaurant. I like New Orleans.
Oh, but
Yeah, I love that restaurant. I like the po' boys. So can I ask you what the clinical presentation would be of 17 hydroxylase deficiency?
I believe they'll have the hypertension with the virilization, right?
They won't. This is awesome. So they won't have viralization, and I have a really stupid reason, then I have a kind of a pathophysiological reason. But can
Mhm.
you looking at the mnemonic only for stupid reasons? Can you kind of tell me why we wouldn't say they have hyperandrogenism on the basis of what we were saying about 21 hydroxylase deficiency.
Oh, yes, because of the arrow, right. So,
Yeah.
yeah.
So
Okay.
17, the number, which has nothing to do with your adrenal gland, is going to have a 1 on the left. And if you remember that left is hypertension and right is androgenism, virilization, which is virilization is like a really intense version of androgenism where females will have clitoromegaly, males might potentially look phenotypically normal, but females will have potential, intersex, characteristics where they have, ambiguous genitalia, potentially have, even have hair in places that normally, female babies, infants would not. And so I'm not telling you that because you don't know it, but because you mentioned a good word, which is the difference between virilization and androgenism is a really good, important one because you have to be very, very hyper androgenic, androgenemic, emic meaning blood, to start presenting with something like clitoromegaly. So if you have clitoromegaly, you are virilized. And if you're virilized, that means you have a really, really high androgen amount. So there are specific pathologies that correspond to virilization. And then there's a larger, broader category of androgen, presenting, hyperandrogenic presenting patients. So thank you, Candace, and welcome to. I think this might be your first session, so you're very welcome.
Yeah.
And so Helen, all right, if this is the same Helen, then I think we've seen you before, but welcome.
Yeah.
Right. So I'm gonna ask you a similar question. So for 11 alpha hydroxylase, what would the clinical picture be?
Hypertension and virilization.
Exactly. You have you will have virilization with these adrenal deficiencies because you have really hyperandrogenism. So virilization that's correct. You will be virilized. So Candace was absolutely right as well. Just be careful when you're talking about things like polycystic ovarian syndrome and other syndromes. You want to be able to categorize which of them is going to get you to an androgenic amount that is actual quote unquote virilizing. So examples of virilization in addition is like hirsutism, where you have like hair in places that are kind of male pattern. So you'll have things like facial hair, even potentially have male pattern, baldness or, because you're hypertestosterone anemic and you have DHA and DHEA and things like that are really androgenic. So I just wanted to go into that quick lecture because it's not one of mine. And I really need to credit the person who made this mnemonic, although it's not copywritten. I just feel like it's a nice contribution to medicine. But I hope that helps because I love that mnemonic and I hated these questions for a while. Although I think you should memorize the pathway and really understand the pathway, the GFR kind of thing that I was drawing, and kind of have a good visual understanding of which is taking you to which pathway and kind of understanding it visually that way. In addition to this, just to cross-reference one another. But let's just get started. So one thing I wanted to start doing also is if anybody has a content question or like has recently done Q banks and wants to just like ask us as a group or ask me as a kind of group. I know it's a lot of pressure, I guess, but if you did want to just ask us a question, you can say so in the comments, or you can chime in. I'll always give you from week to week a chance to just ask a question, and then we'll just get started on the questions from the game. So does anybody have like a question that they know about that they're just like, I didn't understand the explanation, or I'd like to understand it a little better, and if I don't understand it right now, I'll get back to you. Anybody? So maybe you guys can prepare, if you do a bunch of questions and you find one that you just don't want to read the explanation, you don't know enough about it, maybe we can do a primer next week if people have questions. So I'm going to share my screen. So I'll just start explaining the game now as I do share my screen. But we are Borborygmi. We are located on a website called borb.org. And each week we do kind of lecture sessions using the game. So I'm going to stop sharing just for a moment because I need to log in to the game. Here we go. And so there we go. And we have step 1 sessions. We have step 2 sessions. You're welcome to join either, but you have to field questions in both. So if you're feeling less confident with step 1, step 2 is going to be more clinical. So if you're a doctor already, some people are IMGs. I can fully understand being hesitant to do step 1 questions and already knowing step 2. But here we are. It's truly, well and truly, it's a video game that we aspire to make fun. So the idea is to lower your threshold to initiating study sessions and to socialize it so that you can play alongside other people. And so the idea is that on the Facebook group, if you wanted to post a comment and say, I'm starting a session, I'd like to play somebody else in multiplayer at this time with a time zone, then people could join you. And we have a Facebook chat group as well. If you'd like to join that, just let Rowenda know if you're having trouble joining it. And we have a Discord as well. So the idea is that you will have accountability and other people who are preparing for the exam, and we will internationalize preparation so that you guys know about resources and how application works for residency and all of that through one another as kind of a cornucopia melting pot of information sharing and game playing and test preparation. So we're going to create a character here. I have like in the scribe. He's supposed to encourage you to like, comment, and subscribe on the video when you're watching it. If you would turn on your video, it would help me a lot to get people to watch these videos when we do call on you. I'd appreciate it. I'm going to create a new character. I tend to play the same character each time just because I want to encourage people to actually play the game, and it is free to all. So that's another thing, is it's free right now. If you come to these sessions a lot, we're going to have things like giveaways, like UWorld subscriptions and things like that. When we start having a competitive game, we'll have people actually play one another, and I'll compete in the tournament, and hopefully I'll win. But if I lose, then somebody can win a UWorld subscription. So that's what we're hoping to do very soon. So these will be a lot more fun at some point when you can actually participate. So like in the scribe. And we're going to play hardcore mode, where if I die, my character just disappears. So if nobody's playing multiplayer currently, then I'll go into solo mode. But it's a big responsibility because you have to stay in the game until you die if you play multiplayer. So we should probably coordinate that before we do it. Here we go. I'll hide these controls. Okay. And we have a ton of people joining. That's great. Fabulous. All right, welcome everybody. I haven't talked to everyone, but I see a lot of familiar names, so I'm going to keep going and just call people at random to get started playing. So the way that it works, just a real quick rundown, is we have this economy of action points here, and in green, and then we have kind of tiles here in the on the map. The way that you do any action is you have to choose a tile, and if you choose a tile that has actions, then down here you can click them, or you can use the hotkeys associated with them to decide to move. And so I'm going to hit the S key just to demonstrate that. Move here, the parallax is moving, and we're trying to look for an enemy. Usually I find one before we get started teaching, but we didn't. Okay, so now I'm going to hit the space bar. Rowenda, do we have a random name to choose to ask questions to?
Yes. Hi, everyone. Welcome. So, can we start with Helen again? Hi, Helen. Welcome back. Hi.
All right, Helen, welcome. All right, so do you want to read or should I?
Yes, I want to read. Yeah.
All right, let's do it. Let's do it.
A scientist is studying in muscular dystrophy and decided to investigate muscle physiology.
In sorry. In examining biopsies for the changes in the muscle appearance, he noticed that there are multiple different types of muscle fibers. A histologic cross-section of normal human skeletal muscle is shown in the figure A. How do the darker muscle fiber compare to the lighter fibers in terms of relative numbers of mitochondria and amount of glycogen?
All right, so I'm going to show you the image, but have you seen questions like this before? This is kind of like a muscle tissue.
Yeah.
So kind of like typifying characteristics of muscle cells. So let's take a look at the image itself. Wow, we are getting a lot of people this time. Okay, so can you see this?
I cannot see the diagram.
Oh, okay. So it hasn't shown up yet?
No.
Okay, can you see it now?
Yes, yeah. Um, um,
Yeah,
Some fibers
so there's two types of muscle cells, first of all. Do you know what they are? I'll give you an example.
red muscle, like that.
So, well, okay, so there are exactly, you're exactly right. So there's cardiac, there's smooth muscle, and then there's skeletal muscle. And so those are three types in a certain sense, but this is like two types of muscle cells in the sense that they are fast twitch or slow twitch. And so, so which of the two types are going to be darker? So you might not. It's okay if you don't know, but
more mitochondria and less glycogen.
yeah, I think the idea is that the fast twitch muscles are going to have like it's a matter of hemoglobin, myoglobin. I mean, it's a matter of because the pigmentation of the myoglobin is going to cause it to be a little bit darker. But the fast twitch muscles are intended to be high force and contractility. Obviously, low force and contractility, but be able to contract quickly, and refractory period for firing again is small. Whereas the slow twitch muscles are supposed to be more forceful contractions, but take longer to contract and contract less frequently. And so why don't we choose an answer and then we'll read the description? That might be better. So which are you thinking about? You thinking about A?
Yes.
Yeah. So that would suggest that the lighter fibers in terms of relative number of mitochondria and amount of glycogen. So we're talking about the lighter fibers here. So what confidence are you thinking?
Green.
Green. All right, let's do it. All right, nice. So so just to reiterate, we got some action points here, but the figure shows muscle types. We got type 1 fibers appear darker due to increased amounts of myoglobin. So type 1 and type 2 is another way to reference them. There are fast twitch and slow twitch muscles. These are the categories that we're talking about when we say type 1 and type 2. And so the type 1 are abundant mitochondria and perform aerobic metabolism for endurance activity, whereas high intensity activity is going to be abundant in glycogen and anaerobic metabolism. And so you're absolutely right that the lighter fibers are going to be high in mitochondria and lower in glycogen. These are slow twitch muscles. And so the type 1 are slow twitch. So as I described, they're going to be forceful, but they're also for endurance. And they're also for, they're not mentioning it here, but it's also for posture and stability. So your postural muscles will largely be slow twitch because you want to be holding something for a long period of time. And so those kind of distinctive characteristics are really important um, because they they love to test this, and this is like a kernel of knowledge where they really do test it quite a bit. I saw questions on potentially saw questions or have heard of people seeing questions on this exam regularly concerning muscle types. So thank you so much, Helen. That was great. So so Rwanda, who's the next victim we got?
Right. Sure. Let's try Candice. Hi, Candice.
Hi. Are you?
Hello. All right. Okay. So we meet again. We're getting attacked from both sides, so we got to kill some spiders. So do you want to read or should I read it?
You can read.
Okay, I'll read it. Okay. So I'll change the text size here. Okay. So 60-year-old male, emergency room complaining of substernal chest pain. He reports a 3-hour history of dull substernal chest pain that radiates to his left arm and jaw. He has a similar incident 2 months ago after walking 1 mile, but his pain is more severe. But this pain is more severe. So his past medical history is notable for hypertension and hyperlipidemia. An EKG demonstrates a non-specific changes. So serum troponins are normal. In addition to aspirin, oxygen, and morphine, he has started on a medication that generates endothelial nitric oxide. So, which of the following is a downstream effect of this molecule? So, just first off, what are you thinking about when you hear the question? What are your first thoughts? Candice, are you here?
Yes, I'm here.
So what category of question would you put this under?
Well, nitric oxide would dilate. So are they asking like basically what would help dilate?
Yeah, so I think what they're trying to get at is, although this is this is masked and dressed up as if it were a cardiology question but it's really about pathways and drug actions. And so I wouldn't even call this a cardiology question, cardiac question. I would call this a pathway question. So this would be like biochemistry. And there's a really good page in your book on first aid that will cover this in depth. And you should just memorize that whole page because it is 100% going to represent, 3 or 4 or 5 or 10 questions on your exam. And if you don't know it, I think that's probably earmarks your exam to not have a good score. So you really need to know these. It's not like you can't get a good score without it, but it's one of those like USMLE-isms that doctors don't remember this, but students have to know it. So yeah, you're absolutely right. I think endothelial nitric oxide, I think what they're talking about is which of these answer choices represents that drug, in the pathway. So it's okay if you haven't seen this in a while. This is like not something that you see in hospital. So what are you thinking in terms of these answer choices?
Something is just leading me to maybe, I guess I'm stuck between D and E, but I'll go with, I'll go with count production.
Cyclic AMP. Yeah. So,
Yeah.
all right. So which confidence are you thinking?
What I was actually trying to go for, which I'm not 100%, my confidence level on this, I would say is red.
Okay.
Because I remember something about like protein kinase G and all that. And I don't remember Kemp being, um, increasing. Yeah, well, anyways, yeah, my confidence is low on that.
Yeah, no problem. We got killed by spiders, so it's absolutely no consequence we're not feeling confident in that area, because we're gonna have to reboot the game. But I think the answer is actually guanylate cyclase, and that's just kind of because I have to stop sharing for a moment here. I think that's because I associate nitric oxide with cyclic GMP. So that's guanylyl monophosphate. And so the cyclic version is the type that is the molecule that you will see most often associated with activating the, in the G protein coupled receptor pathway for many drugs. It will be associated with like nitric oxide. And so before I move on to another game, actually, I'm going to do something else. I'm going to show you guys the game review option, and we're going to review that question so we can see the absolute answer unequivocally, and then we'll continue on. So let's see here. Game log. Go to the bottom, and we have this question here. Types of muscle fibers. So apparently we have to answer the question for it to show up in the game log, unfortunately. So we're going to fix that because that's not good, because once you see a question, you certainly want to see the explanation. So I apologize for that. We're still early days. That's why we're offering the game for free. But we'll certainly be fixing that aspect. And let's share screen here. Are you able to see my screen? Okay. So if you like, Candace, we can give you another shot at this. I'm going to maybe take a potion here. See if that works. Okay. So yeah, that works. So Candace, I'm pretty confident that cyclic GMP is the answer, and so that would be taking GTP and changing it to cyclic GMP, and so that will the action of that drug actually causes the smooth muscle in the vasculature of your arteries to relax and stop contracting, because smooth muscle acts differently from other types of muscle. Skeletal muscle will act differently, and if you have more cyclic GMP, you're actually going to be less contracted. So you're going to have less muscle tone, if I remember correctly. So you guys hold me to task on that and send me a chat if you don't agree with that. But I'm pretty confident that was the answer. Let me know. And I'll make a correction for Candace as well. If I'm wrong, I will give her credit in the video. So thank you for answering your question, Candace. Rowenda, who is the next person to talk to here?
Sure. Let's try Bushan. Hi, Bushan. Welcome back.
There you go. All right. Can you hear me, Bashan? You might be getting situated
Yeah, I
here.
can hear you.
Okay, great. Would you like me to read, or usually you read?
Yeah, can you read the question, please?
Okay, all right. So research team wants to determine whether they are prenatal factors associated with cleft lip in families who have no previous history on cleft lip. The research team decides to focus on all newly diagnosed children with cleft lip, at their children's hospital in the last 2 years. They will then compare this group to a matched group of children without cleft lip. So all subjects with a family history of cleft lip or other craniofacial syndromes will be excluded from the study. So all subjects' families will be sent a survey assessing for prenatal factors that may have been associated with cleft lip disease. What type of study is this, and what kind of outcome measure will it determine? So we have a survey assessing the prenatal factors, which are risk factors. So I'll just let you think out loud before I talk about it. But what are you thinking about?
I haven't studied statistics yet, so I don't know the answer to this.
Okay, so I'm gonna lay down some like facts, and then we'll talk about the question before I give out what I think is the answer or anything like that. But basically, the way that I think about case control is you have the way that I remember it is there's this unbelievably good YouTube channel by this guy Neil something. You're gonna have to look him up, but he won't be hard to find. You Google Neil and you Google public health USMLE questions, things like that. You will definitely come up with him. And so case control studies are studies where you're comparing a control group with a group that has disease. The case in case control refers to people who are cases of a certain pathology. So it's easier to remember if you understand why the word is the way that it is. Case control meaning people who have the disease, control meaning people who don't have the disease, because we need people who don't have the disease to compare to the people who have the disease. With the thing that you would really compare to case control is a cohort study. And a cohort study has two O's in it. Two O's meaning two control, like kind of control groups, in the sense that what you're doing is you're going back in time and you're looking for risk factors. What you're doing is you're not starting with a group that has the disease. You're starting with a group that doesn't have the disease. So it has no A in it. And so because A in case represents people with the disease, and O in control represents people who don't. And so what you do with a case control study is you start with disease and you go back for risk factors. With a cohort study that's retrospective, you would do something similar, except you would go back in time to look at what risk factors people have, and then you observe over time whether or not they develop the disease. So it's a really different order of operations, because you're starting now and you're looking at risk factors to see what happens later in a cohort study, where I said retrospective, but I meant prospective cohort study. Whereas a case control study, you're looking for risk factors in the past, which in the context of people who currently have the disease and people who don't currently have the disease. And that's what I think of when I hear this question. If I was going to talk about cross-sectional analysis, I would be talking about a certain snapshot in time. That's what a cross-section is. And then I'd be hearing about certain details about a certain population that exists right now. There's no waiting for them to develop anything. There's no looking at risk factors from the past. We're looking at what risk factors coincide in time with what we're assessing. And so if that helps at all. So this has nothing to do with cleft lip, in the sense that you don't have to know anything about cleft lip to get this question right. It's really a public health question. So now that I've talked about it a little bit, are you more interested in one answer choice than another?
I don't really understand the topic yet.
Okay. Yeah. So I think the thing to do when you have questions like this is to go into the question thinking after reading the answer choices. You read the question sentence, you read the answer choices, then you start at the top, right? That's the order of operations that a lot of people use. You don't have to use that, but you can. And so what I would do is I would say, is this a group of people that we know have a disease? And the answer is, we're focusing on newly diagnosed children with cleft lip. And they will be compared to a group of matched children without cleft lip. So if we're starting with people who have a disease, is that what I described to be case control or cohort?
That would be core. Wait, no, that would be case control.
Yeah, case control. Because we're starting with people who have the disease, that's the A in case, and people who don't have the disease, that's the control group. The control group is the people that we're comparing to the people who have the disease. And then we're going back in time to look at whether they have risk factors. So I kind of gave you the answer because I wanted you to get something out of the question instead of just, trying it. So which answer choice are you thinking?
So it would be D, right?
Yes, D, I believe. Yeah. So actually, I'm sorry. D is a good answer, but the problem with D is that the relative risk, and this is just a detail that I didn't include, but the relative risk is going to be a number that you obtain on the basis um, of whether or not you are doing a cohort study or a case control study. When you're doing a cohort study, you're doing relative risk, and when you're doing case control, you're doing odds ratio. And so that's the distinction there. Let's choose odds ratio. Let's choose relative risk, and we'll just do medium confidence because I think this is like which confidence. Yeah, I mean I kind of gave you the answer, so let's do medium confidence here. I'm sorry to have robbed you of guessing, but I think this is more like a learning opportunity than it is a game that we're playing because these lectures are kind of more about learning. So I appreciate your willingness to try to field questions and provide an answer when you haven't studied something yet. I don't expect people to get things right before they study them. That would be like psychic. So thank you for answering those questions. So Rowenda, who else do we have next if we could?
Sure. Let's try AJ. Hi, AJ. Welcome back.
Hi.
Hello, can you hear me?
Hello. Yes. Can you hear me? All right.
Yes.
Obviously. Yeah. Okay. Would you like to read or should I?
Can you read?
Yes. So you are called to evaluate a newborn. The patient was born yesterday to a 39-year-old mother. You observe the findings illustrated in figures A through C. What is the most likely mechanism responsible for these findings? So you observe A through C. It's a newborn. All right. So A. So what are you seeing in A?
I don't know. Is the apicantal fold the eyes?
Ah, okay. Yeah, potentially. Potentially, are you saying that they're up slanting or they're? I almost feel like I can't see where the epicanthal fold is really whether it's up or down slanting or whether it's not particularly pronounced. But I think there's something else that's kind of more pressing about this image. If you just saw this baby, would you? Can I give you a hint?
I don't know.
I'll give you a hint. No problem. One of the things when you're looking at these images that you can always do to help you, like if let's say that you had no idea what was weird about this image at all, one good thing to do first, because you don't want to skip the image right away. You want to try to identify something that is abnormal about it if you can. You don't want to spend too much time on it if you can't. But one of the things that I would always do is say, is this symmetrical? So is this person's face, symmetrical to you?
No.
Okay. So what is the distinguishing feature from one side to the other?
The right side of your face is sort of puffy or something.
Are you saying the patient's right side or my right side? Like looking at the image, is it the right side of the image?
No, sorry. The
when you look at it, it's the right side, right? Yeah. So I think it's this area that's really enlarged.
Yes.
I could be wrong, but I think it's puffy. Um, and I'm not sure if there's yellowing of the eyes. I'm not sure about that. Um, welcome, Kevin. We're doing a question here, but you're very welcome. Thank you for joining us. So what do you notice here? AJ, if you're here.
Toe photo separated.
You
I'm
what?
sorry, I'm just starting to study and I don't know. I don't really know the stuff. The toe is sort of separated from the rest of the fingers.
Yeah, yeah.
Slightly
Absolutely. I think that's the only thing I noticed too. Maybe a little bit of, skin here. I don't think that's going to be something that they mention. Maybe it's like some rashy kind of redness to the foot, but I think you're right. This is potentially anatomically abnormal. And hemathocala, I hope I'm pronouncing that right. I'm certainly trying to. Um, Randy Neal is absolutely right. I'm just reading these comments. Absolutely. And case control is actually associated with odds ratio, and so that's a nice thing to remember. Also, odds ratio. Neil, you got to watch those Randy Neal videos. They're summaries. If they're not summaries, they're not the right videos. But those are absolutely lovely. So I'm just reading those comments in the middle of our question here. I'm sorry. So look at this. So what do you notice about this hand here?
The cement piece, the line in the palm.
Yes, exactly. So what do you notice about it?
It's more pronounced than usual.
Are you able to see my drawing here?
Yes.
So this is what we call so the palmar crease is, we have like a one palmar crease, right? But in a normal person, you'll actually see in my hand, you have, if you can see this, the background's not going to let you do it, so I'm going to draw it. But usually the palmar crease will look something like this. And then there will be a downward slant here. And so people who read your palm, if you have a palmar crease like this, they might tell you that you have a certain genetic disorder if you have a line like this. Now, you can be perfectly genetically normal and have a central crease like this. There's only a single palmar crease. But it is correlated, and these are all kind of patternistically distributed genetic disorders. But no one sign is going to tell you that you have any genetic disorder, but that is definitely a hint. So I will get rid of the annotations. Clear. Okay. So what are you thinking in terms of answer choices now that we have three kind of weird things going on?
Trisomy 21, A.
Yeah. And I'm just gonna. I think. In what confidence are you thinking?
Because of the third image, I'm pretty confident on this one.
Yeah. I think that's right. That's the good intuition, because that specific characteristic is like in the USMLE step 1, although it's not a huge corollary with trisomy 21 in real life in terms of like you can have it and not have trisomy 21, but they love to mention that as a distinguishing feature from other pathologies. So what you would really be looking for is a patient with mental retardation who also has a palmar crease that is one central palmar crease. So if you have both of those things, then you're really talking about a single palmar crease. Yeah. So hemathocala, exactly. And so so we're saying green. So I just want to take this as an opportunity, because we're already at 406 seconds, and that's because of me. But do you know the pathophysiology of trisomy 21? Do you know why all of these things happen to trisomy 21 people? It's kind of cool.
Because of that strut chromosome.
Because of what?
So that strut chromosome, trisomy.
Yeah, absolutely. Yeah, so I asked that question a little bit ambiguously, but you're absolutely right. It's you're gonna have 3 copies of you're going to have 3 copies of, you're going to have extra copy of the 21st chromosome. And another problem with that is, of course, you're going to have, it turns out that the disorder that you can have for Alzheimer's in the beta amyloid that you can produce from that is also on the 21st chromosome, and people with trisomy 21 wind up having higher risk for Alzheimer's, even early onset Alzheimer's. But non-disjunction is absolutely right, hematocola. And it is mitotic. That's a good point. It is mitotic disjunction. That's another thing that we should probably know. Another thing to keep in mind is they like to talk about it like it's a neural crest cell migration disorder. So that's really the pathophysiology of it, is that neural crest cells are not able to migrate to the locations that they would need to be at in order to establish specific clinical, clinically normal presentation. And so, so McKenna-Lee, I'm trying to add you to the group. I hope she can join the video. So let's get this right, because I think you got it right, absolutely. And let's read about what that foot phenomenon is and what the face phenomenon is, because I don't want to lead you astray. So figure A, it says, shows a classic facial feature seen in Down syndrome: flattened nasal bridge and epicanthal folds. So you're absolutely right about the epicanthal folds, and I am absolutely wrong about the puffy face. Although I think you have a lack of muscle tone and you can have some puffy face, and if this person has Down syndrome, it might be an additional feature. But like you were saying, the epicanthal folds, they're going to be up slanting epicanthal folds, and you're going to have flattening of the nasal bridge. You might be able to see that here in this image. So the nasal bridge is this bridge here, and usually there'd be a little bit. So this is going to be flattening of the nasal bridge. Sorry to draw on this baby's face. I'm not trying to disparage this baby's. So figure B demonstrates increased gap between the first and second toes. You're absolutely right on that. And then the single palmar crease. So I hope I didn't labor that point too much. I just think trisomy 21's, of the abnormalities that you can have, trisomy 21 is certainly going to be a very high yield thing to understand a lot about. And if they explain why this illustration is included, classic feature of trisomy 18, which is Edwards syndrome, is going to be, note the low set ears and clenched fists. So they have also rocker bottom feet, as you can see, and he has other features of Edwards. He might even have a something that you see in Marfan's, which is a. So these are all kind of cornucopia of genetic features here, but you can have what's pex excavatum, I think it's called, where you have kind of your complex is kind of excavated, concave. So thank you so much for answering those questions and getting it correct. And we're going to move over here, and potentially we'll need to skill up. I'll press Z, and then I will skill up some of these by pressing U, and I'll press U a bunch of times to skill this up. We're going to wind up killing things really easily, and that's just because we are testing the game out, and we have made these skills a little more powerful for teaching. So I'm going to shoot this snake. Apparently it's a snake. And I missed him, so we have to answer a question, guys, because we can't die again. If we die twice, it'll be the first time ever. So Rowenda, who's next?
Sure. Hi, Hema Soala.
Are you there? We might. So Hema Thokala, are you here? Oh, you can't talk.
Oh,
Okay.
yeah.
Yes, sorry, I cannot talk.
Okay, that's all right.
Yeah.
So what we do sometimes, because you've been participating in the chat so much, I would feel bad if we couldn't do a question for you. So we're going to do a question with you, if you don't mind, in the chat. So could you respond to it with chats? Is that all right? Okay. I'm just going to get started so yes. Okay. So 25-year-old male presents with progressively worsening headaches. Progressively over the past 2 months. He also feels that he has been losing his balance more often over the past week, but he denies any motor weakness or sensory impairment. His neurological exam reveals impaired upward gaze. Pupils still constrict poorly with light, but react to accommodation, and bilateral upper eyelid retraction. On tandem walking, he tends to fall on both sides, meaning he doesn't fall to one side more than the other. And the remainder of physical examination is unremarkable. What is the most likely diagnosis in this patient? What are you guys thinking? Pineal tumor. All right. So why are you thinking pineal tumor? I think that's a good thought. Upward gaze. Yeah. Do you know what that syndrome's called? Paranod syndrome. Exactly. Okay. All right. Well, you're killing it. Hematocola. You guys, if we do chat, you guys can just chime in as well. I might even keep the chat open so people can just comment if you guys don't mind. So which of these answer choices corresponds to what you were thinking about? C, right? So what confidence are you going with? And yeah, so probably C. So do you want green, yellow, or red? Let's face it, it's green. Okay, so I'm going to keep the chat open, obviously. So can I ask you some additional questions? So upward gaze. What cranial nerve will lift your eyeballs upwards? Three, AB says. Okay. So we have a vote for three. Hematocola says three as well. All right, the snake's killing us, so I'm going to kill the snake real quick before we all die. We killed the snake. We have nothing to worry about, you guys. Okay, so three, everybody's saying. All right, so let's read the explanation here. So it's true that if you have a third cranial nerve palsy, you'll be down and out. And that's the way to think about it, that your eye will be turned to the external to the, so you have the nasal visual field, and then you have the, I've lost the term. So there's nasal, and then there is, do you guys want to help me with that word? But effectively, when you have a pineal tumor, it's pressing up against a cranial nerve. So you guys are going to help me here. Temporal. Thank you so much. It is temporal. And so what happens is the pineal tumor presses up against compresses the superior colliculi and the pretectal area. And these areas harbor connections for the cranial nerves that would allow you to raise your eyes. And so as a consequence of the compression from the pineal tumor, you get Paranod syndrome where you're unable to raise your eyes. And so one of the consequences of that is when you're trying to walk up the stairs, patients will say that they have to turn their head up in order to see the stairs above them. So there's like clinical features that you can ask questions about that will allow you to identify the person has Paranod. So thank you so much, Hema that was great. We killed a snake as a result, so we didn't die. So Rowenda, who's next on the list as well?
Yes, let's try Ume. Hi, Ume. Welcome back.
Ume, welcome back. All right, I'm going to take some health potions so we don't die as well. And why don't we check to see if we're thirsty? Because we now have a thirst mechanic. Okay, so I have 10% thirst, so I'm going to drink some water. Stay hydrated, guys. Absolutely, absolutely, Hema. By the way, if you would say in the chat where you're from, I'm just curious. I'd like to know how many countries we're reaching. Um, all right. So I'm ready. Uma, would you like to read?
Yeah, I will read.
Okay. By the way, I always like when people like to read because I like to see how they're thinking about the question in real time. So I'll highlight as you go. Can you see it?
Yeah, a 53 years old male presents to the primary care physician complaining of fatigue and joint and muscle pain. He reports a 6-month history of slowly progressive tiredness associated with dull, achy pain in his knee, hips, and shoulders. His past medical history is notable for hypertension, diabetes, and a stable angina. He takes lisinopril, metformin, glyburide, and aspirin. He has a history of intravenous drug use and was homeless in the early 30s. He drinks alcohol socially and has a 30 pack year smoking history. His temperature is 98.6 degree Fahrenheit, 37 degrees Celsius. Blood pressure is 130 by 85. Pulse 95 and respiration are 18 per minute. Physical examination reveals a generally well appearing male without evidence of ascites, peripheral edema, or jaundice. Results from laboratory tests are below. Interferon alpha, interferon gamma, lumividin, ribopin, and sotovirin, and ciminipir.
Yeah. So what are you thinking about? Oh, I'm sorry. We got to keep going. Sorry. Excuse me. So what do we have positive here? I'm just going to highlight.
Yes. Okay. Hepatitis A negative. Hepatitis A negative.
Yeah.
B surface. Okay. Hepatitis B surface IgG positive. Hepatitis IgG positive. And HCV RNA.
Yeah.
Okay.
So how do you think about being positive for hepatitis C IgG? Let's do that first.
Because their question there is he's homeless for 30 years, early 30s, then history of alcohol, smoking, and
Yeah. So is hepatitis C something that you could be cured of?
no, it cannot be cured of.
So until recently, you were absolutely right. But we have recently developed an ability to get rid of hepatitis C. So, but you will still have IgG antibodies against hepatitis C.
Okay.
So the fact that we see IgG could mean that he is status post hepatitis C infection.
Yeah.
But how do you think? So I would categorize this potentially as also, what is the difference between IgG and IgM antibodies?
IgG is old, just carrying. IgM is new.
Yeah, IgM is like acute, and IgG is going to be like you've developed kind of chronic, reaction to it at the very least. Yeah.
Chronic or new.
Right. Exactly. Yeah. And so I know you know those differences. I'm just restating it in a way that I would put it. So I recognize that it's hard when I'm asking questions on the spot, but so hepatitis B is, of all the hepatitises, is the one that they test the most. And the reason for that is we have a really robust system for testing hepatitis B that involves different types of immunoglobulins. And those immunoglobulins will signify where in the infection phases you are. they're not called phases, but there's a window period. There is a period where you are negative for an antibody that you might expect someone to have if they had the infection. And then there is an acute infection kind of series of immunoglobulins that you'll have. And then there are post-infectious immunoglobulins that you'll have such that you won't be symptomatic anymore. You will have kind of developed an immunity to hepatitis B, but you will be you will have antibodies in your body. And so there's a difference between having an antigen versus an antibody. That's the first thing to notice, is that there are antigens and then there are antibodies. And then there's also a distinction to be made between whether you are talking about surface, core, envelope. Those are really the main things that you can have antibodies. So versus having an antibody against the antigen itself. So another thing to notice.
Last.
Yeah. So what does E represent to you?
Against this medication is effective against hepatitis C virus.
Yeah. So we have lumivudine. We have interferon gamma. Interferon gamma would also be a treatment, I believe, for hepatitis C as well. Interferon alpha, ribavirin, sofosbuvir, and cimeprevir. So if I remember correctly, I think sofosbuvir and cimeprevir are hepatitis B. But what do you think about this RNA being 100 million units per milliliter? What are you thinking? So RNA, what does RNA signify to you? It's okay. I'm putting you on the spot. I'm making it hard for you because you've been here before and you put up with me before. and I know that you've answered a lot of questions correctly. I know that you've been studying. So I'm picking on you because I know you can take it. But RNA is going to be a signify that we're transcribing DNA. And if we're transcribing viral DNA, then we have an active infection. If the titer for HCV RNA is high enough, then we have an active infection. But we also know that we have an active infection going on for another reason, because we're symptomatic. We have dull, achy pain in the knees, which is a viral sign of any viral illness. We have slow progressive tiredness, which is a sign of hepatitis, certainly. We don't have late stage because we don't have ascites or jaundice or edema. But and we also have a history of IV drug use, which is a risk factor for HCV as well as HBV. So hepatitis A is more associated with fecal eating something that has human feces in it or feces in it, but in your water supply or something like that. But so given those features, we can also talk about hepatitis B. How do you think about the fact that there is a surface immunoglobulin here that is positive? What do you think about the surface antibody? It's okay if you don't know. This is like this is a good thing for step one. That I just think hepatitis B, hit it hard. This is a really good one that it's not a waste of your time to study it. And it's really complicated, by the way. And a lot of people get these questions wrong. I've been teaching for a long time. I've been thinking about this for a long time. People get hepatitis B questions wrong up to their exam and in their exam all the time, because there's a lot of waves and things like that. But the broad strokes way to understand it is the surface of the virus is going to be, you only get, if you have an IgG for the surface, then you are, quote unquote, you're cured. You don't have hepatitis B anymore. If you have anti-core, but you could be cured because of a vaccine or from infection. But if you have hepatitis B core antibody, not the antigen, but the antibody. So if I have core IgG positive, that means that I have a past infection that I've gotten over as well. And so, because only with an active infection will you see the core antigen at all. The viral, the like attenuated virus that you get from the vaccine does not have a core in it, and so you won't develop antibodies to the core. So which answer choice do you want to go with, and we'll kind of talk about it after seeing the answer.
Okay, I will go with C, not
C.
not
Okay.
D. E. C.
I talked you out of E, so are you sure you want to go with C? Okay, because somebody said
Yeah, yeah.
suppose here. So which confidence are you going to go with? I'm not certain of the
Green.
answer here. Okay, let's go
Green.
green here. Okay, so I talked you out
Oh
of the right
shit.
answer. So don't
Yeah.
listen to me for the answer choices because I might talk you out of a good thing here. So I'll congratulate you on getting the correct answers. Hepatitis C is treated with sofosbuvir, and cimeprevir. So hemothocla is absolutely right as well. Um, and RNA-dependent polymerase inhibitors, protease inhibitors. Let me know in the feedback if you guys want me to have the chat on. The problem with having the chat on, in my mind, is potentially people can read the answer of other people, and that will allow them to know the answer before we think about it and talk about it, and it will deny them the ability to get it right publicly, which is a nice feature of the. So let me know what you guys think. But thank you so much, Uma. We will get vindicated with another question. I appreciate your willingness to talk about it for a long time because I just love that topic as a source for points on the exam. But so Rwenda, who's next in line if we could?
Yeah, sure. Let's go with
Thanks.
Amandeep. Hi.
Hello.
Hello, Amandeep. Everybody thank Rwenda, by the way. She makes these things possible, so I appreciate that very much. Amandeep, all right. So do you want to read or should I?
Can you read?
Absolutely, absolutely.
Thank you so much.
All right. So 58-year-old man presents to the primary care physician because he has been experiencing shortness of breath. In particular, his office decided to go bowling together. He had to sit down after half a round because he was very fatigued. So, in addition, he has been experiencing palpitations and occasionally has dizzy spells where he feels like he is going to faint. Based on this presentation, appropriate tests are performed and the patient is started on medication. 1 week later, the patient is brought to the emergency department after he passed out at work. An electrocardiogram of his patient is taken at the time of presentation and results in figure A. Which of the following drugs was most likely responsible for this patient's emergency room presentation? So I'll just show you a picture. So what are you seeing when you look at that?
It looks like ventricular tachycardia.
Absolutely. So would you call that monomorphic or polyphasic, or how would you think of it? I would call it
I
like
don't know that deep.
okay. I think monomorphic maybe because it looks like it's only one kind of shape. Um, would you call this something like torsades or no?
Mm, no, I won't say
No,
that.
I don't think so. I think you're right. I think torsades is probably, torsades looks a little different. So all right, so that's great. So which of these answer choices are you thinking about? Which of these drugs most likely responsible for this patient's emergency room presentation? Are you thinking?
Actually, I'm confused.
Yeah, because I think they like to give VTAC as a consequence of drugs when it is torsades, right?
Yes, yes.
So maybe it was a little torsadesy, but we'll see. I think you're right that this is ventricular tachycardia. So I'll tell you what I think, but don't necessarily listen to me because I've been wrong before. So which of these drugs, if it was torsades, would cause torsades in your mind?
Maybe lidocaine.
Yeah, so HA is thinking lidocaine as well. Lidocaine, I believe, does. So one of the ways to think about this is which group is it in? So is it a 1A, 1B, 1C drug? Is it a
1B.
Yeah? So
It's 1B.
1C, right? So 1B you said, or 1C?
I said 1B.
1B, okay. And then we have we have two type 2 drugs, which are like, do you know what those are? Those are beta blockers?
Yeah, metoprolol, propranolol.
Yeah. Exactly. Those are the heart specific beta blockers. And then you have type 3, which are like, includes amiodarone and sotalol and a bunch of drugs which act on potassium channels. And then you have type 4, which are usually calcium blockers. So we have two votes for lidocaine now. But what do you think it is, and what confidence do you have?
I think it's lidocaine.
Okay. Do you want to go green, yellow, or red?
Yellow.
Yellow. Okay, let's do it. All right. So we all. I think that's a tricky question. These are very, very high yield questions that I hate. I hate antiarrhythmics, but I think they're very important. They're also very clinically important to your patients, especially if there's going to be, no matter what you do, even if you do psychiatry, people are going to be on antiarrhythmic drugs. They're going to be older patients. This was torsades Dupont. And so I think you see a little point here. This is, so if I could draw it, I would. But basically, if you follow my mouse, it goes up, it goes down, it goes up again.
You're right. Yeah. Yes, I can
Yeah.
see that.
So that's the only point I see. And then I see a bunch of, turns here as well. So it's hard to notice, absolutely. But I think they are saying that that's torsades. And so you're absolutely right that this is a class 1, but it is class 1A that the ibutylide that is implicated. So let's read the lidocaine answer choice. You're right that it's 1B. Sodium channel blocker. It is not associated with development of torsades. So what type of ion would you expect it to be if you were going to produce torsades? It'd be potassium, right? Class 3.
Yeah.
And so you have side effects with 1A and class 3 antiarrhythmic medications because 1A tend to also have potassium channel blocking. So ibutylide falls in this category. And so what I would do is I would have two areas of memory for this one. I would say ibutylide is a potassium channel blocker. I would say that in my head. And then I would also say that it's a class 3. And I would just memorize that ibutylide causes torsades occasionally. So I would memorize it in like different ways, so that when I think about it on the exam and somebody says ibutylide, I don't just say, oh, that's a class 3 antiarrhythmic. I also say, that causes torsades. So I like skip the whole thought process and I go straight for the jugular to get the question right. And then you learn the mechanisms as well. Now, I tell you that in the context of us getting the question wrong, but that's how I would memorize it if I was going to try to get it right the next time. But thank you, Amandeep. We will have further questions. Don't worry. I get questions wrong as often as you guys do, so I appreciate your willingness to speak and answer questions with us. So, Rowenda, who's the next person?
Yes. Let's try Kelvin. Hi, Kelvin.
Calvin, are you here? Okay, Calvin. No problem. I'm hoping we can connect again. And if you're hearing this, then just try to connect your audio and let us know when you're back. Ruendo, who's next in the generator if we could?
Sure. Let's try Oche. Oche, hi.
Hello, can you hear me?
Hello, yes, thank you for joining us. Can I ask you where are you coming from, Oche?
I'm from Nigeria, but I'm currently in Switzerland.
Oh wow, all right. Well, that sounds nice. I've not been to Nigeria. I've not been to Switzerland. I've actually been to Switzerland once, but it was gorgeous.
All right.
So you're very welcome. Thank you for joining us. So would you like to read or should I?
I don't mind reading.
Okay, that would be great. I always encourage people to read. I think it's better if you do read it yourself.
A 30-year-old woman presents to the clinic with shortness of breath while on a hiking and skiing trip in Colorado.
Ah.
She explains that this was the first time she has gone this high in the mountain and is slightly concerned as she becomes more short of breath with physical activity than prior to her trip. She is otherwise healthy and her physical exam and vitals are unremarkable. The patient is reassured that she is in good health. She plans to stay on this trip for 2 months. At the end of the patient's trip, which of the following most likely seen in the patient? Oh, mountain.
So what category do you think this question's in? The category of knowledge.
I think what is this called again?
It would be a really it's probably how long have you been in Switzerland?
Well, this will be my second year. I think it's a ventilation.
Yeah. So okay. So you probably have some of these characteristics if you're going from Nigeria to Switzerland. So this is like a physiological changes of altitude. So as
Yeah.
you change altitude, you'll have different physiological changes occur.
Yeah.
And so this is like a little kernel that they've I think it's getting higher and higher yield. You see it a lot on the Kaplan, questions and things like that. I think it's really useful to learn it.
Okay.
So what would you expect if you went up in altitude? In terms looking at these answer choices as categories, like what would happen to your carbon dioxide, your 2,3 bisphosphoglycerate, your pH of your blood? How do you think about that?
Maybe like we will have like what do they call it? Oxygen levels, which is going to drop.
Right. So the problem is,
or you can have decreased or increased oxygen level as you ascend to more altitude.
right. So you have a change in altitude that is causing the partial pressure of the air that you're breathing, which is not all construed of oxygen, it's mostly nitrogen. And so
Yes.
it changes the partial pressure of oxygen changes at higher altitudes because at higher altitudes you're closer to space outside of our outside of our atmosphere. And so when you're closer to the to the stratosphere, you have less air pushing down upon you, and as a result, you're getting less partial pressure of oxygen. And so you will have less oxygen. So you might, for the first month or so, have hyperventilation, where your respiratory rate will increase. And if your respiratory rate increases, then your pH goes up, right? Because you're going to be getting rid of carbon dioxide, right?
Yes.
So what else? What about this 2,3 bisphosphoglycerate? What are you thinking about for that?
I'm thinking that the levels are going to increase in the blood.
Yeah. So 2,3-bisphosphoglycerate is able to bind oxygen. It allows hemoglobin to have more affinity to oxygen. And so it's able to kind of glom up. The hemoglobin wants to bind oxygen within your red blood cells and then deliver it to the tissues. So it doesn't want to bind oxygen too tightly, because if it does that, it won't release it in the tissues. Like a fetal hemoglobin stronger than adult hemoglobin, and it latches onto the oxygen more tightly to keep it from giving it to the mother. And so 2,3-bisphosphoglycerate is an attempt to do that, to almost like it's analogous to having fetal hemoglobin in a way. And so you'll have an increase in red blood cells. You have an increase in 2,3-bisphosphoglycerate. You'll have for the first, like acutely, your first change will start breathing, hyperventilating, not hyperventilating, but ventilating more because you have less oxygen partial pressure. And then your CO2 will be low. But throughout the course of several months, you might actually have a feature of accommodation that's more chronic, like 2,3-bisphosphoglycerate in your blood changing. And that will change the kind of the way that your hemoglobin behaves. So I've explained a lot of things. I'm explaining a lot more than I usually do. But I feel like these are really good questions right now. So what answer choice are you thinking about? Amandeep is voting for B.
I'm thinking of D.
D. Okay. D is in dog. Okay. And so increase in arterial content of oxygen. All right. So increase in arterial content of oxygen. So what confidence are you?
Hello. What did you say?
Are you thinking D? D is in dog?
Yeah. No,
okay.
No, sorry. Yeah, I'm thinking of D. Increase arterial content of oxygen.
Okay. Ume's voting read too. So what confidence are you thinking?
Because like the patient is basically based on the event is experiencing symptoms of altitude sickness due to like the decrease in levels of oxygen that because she's in high altitude.
Yeah.
So as she's going to like spend more time there because she's not going home immediately, she's going to spend more time at the mountain. Her body will like definitely be used to like acclimatize to like low oxygen levels.
So you're reading this as the end of the patient's trip is when she gets back home.
Yes, that's what I'm trying to like. That's where I'm coming from.
So what confidence do you have? Red, green, or yellow?
I would say yellow because there might also be like increase in like 2,3 biphosphate glyceride because it's normally that was the
answer. So this is obviously not a problem with your medical education and your understanding of what's going on, because you read the question to mean that the end of the patient's trip means that they're going to be back home.
Yeah.
But they're not going to be, in this question, they're asking, like, before they leave, at the end of their trip, what are the physiological changes you would expect to have happened chronically, long term?
Oh, not when they are home.
Yeah. And so,
I think that was I got it wrong.
Yeah, and look, we get people from all over the world, and I don't know if English is your first language or not. Sometimes people have difficulty with that. It sounds like your English is really strong, but this sentence is difficult because it's not even about English, really. It's about like, what do you interpret the end of a patient's trip to mean? But I will say this: one of the ways to prevent that problem is to say to yourself, why would they write this question? Like, what are they getting at? What is the testing objective? And usually they're going to test you on the basis of what happened to the person when they're high altitude currently. So you can, if there's an ambiguous sentence and you're saying, I don't know if they're testing me on whether this patient is high altitude now or was high altitude, you want to I think you want to err on the side of the person being at high altitude currently, because that's when the way they usually write those questions. So it's just another like way to think about the question is to say, what do they usually test on? And I'm just going to assume that they're testing on that. It's not obvious, and they could certainly test you on what would happen if you went back home, because it's just the reverse. It's the question in the reverse. You'll have decreased bisphosphoglycerate. You'll have more acidic blood. You'll have more CO2. You'll have, uh, less red blood cells, less hemoglobin concentration. So these are things that change with altitude. But that's a really good question, and I think a lot of people read it the way that you did as well. That's why people were choosing B, and that was the correct answer, is because chronically you'll have 2,3 bisphosphoglycerate, as we discussed. But you know that, and so sometimes there are going to be questions like that that are not even testing your medical knowledge. And I think that's a big part of preparing for the exam is noticing that they write questions that cause you to think about the question differently, even though it's not a medical mistake. So those are really good things to. There's a lot of test taking strategies for that help. So I would write that down, and I would study that as if it were a fact on the USMLE exam, because it's going to come up again. You're going to get 1,000, 5,000 questions before you take it. So at least. So thank you so much, and you'll be vindicated. We'll ask you another question before long. So, Rowenda, do we have another person to ask?
Yes.
All right.
Hi, Abdul Musan. Hi.
Abdul, are you with us? Rowenda, could you send a link to the YouTube as well in the chat?
Sure.
Thank you.
Sure. I'll do that now.
So do we also, could we get another name as well? I think Abdul might not be.
Sure. Let's go back to Kelvin. Hi, Kelvin. Hope your audio is good now.
Kelvin, hello. I'm going to do something real quick. I shouldn't do this in video, but I'm going to do it anyway. I coded something that I use hotkeys for, and it helps me to make certain windows not go away. And I'm going to make the chat thing not go away. So Kelvin, are you here? All right, so we might need another name, Rowenda, if you could.
Sure. Okay, hang on.
One thing to notice is that this chat is not completely useless. It tells us whether the question that we're answering is adding hit points, or whether we're too thirsty to move on, or if we're dying on the basis of being attacked by something we can't see yet. And so it'll give us information, like if you smell an ogre, it'll tell you that you smell an ogre. Or if it's getting too dark for you to see, it'll tell you why the mini map is not revealing locations and things like that. If you have an intuition as a wizard as to why something is evil, or an evil presence is nearby, you'll have that. Proximity sense, all sorts of interesting things can happen in the chat. So I'm covering it up for now, but it's an interesting way to do it. So Rowenda, what's the next name of the next question, if we could?
Yes. We have Sieda there, but she is in the hospital right now.
Okay.
Sieda, would you like to answer?
Sweta, would you like me to read the question for you and you can try to answer? Okay. Oh, that's you. Okay. All right. Welcome. I'll do that now. All right. So ordinarily I like to discourage that from happening multiple times in a row, but I appreciate that you're attending, and we will do that today. But I genuinely appreciate it. I don't want to harp on that. But let's see. So 60-year-old man with a history of osteoarthritis has been awaiting hip replacement surgery for 3 years. During his annual physical, he reports that he has been taking over the counter medications, but is taking over the counter medication, but no amount of analgesics can relieve his constant pain. Laboratory results reveal that his renal function has deteriorated when compared to his last office visit 2 years ago. Serum creatinine is 2 milligrams per deciliter, and urinalysis shows a +1 proteinuria. So there are no abnormalities seen on microscopy of the urine. A renal biopsy shows eosinophilic infiltrates and diffuse parenchymal inflammation. So what is the most likely explanation for this patient's deterioration in renal function? All right. So what are you thinking? What kind of answer choices are we going? How would you characterize these answer choices? And it's going to be hard to ask you really in-depth questions here, but nephrotic or exactly. I think you should characterize this as: is this a nephrotic? Is this nephritic? Is this one really common thing when you're talking about medications is also if you have renal tubular acidosis. So if it's nephrotic, which answer choice it's hard to quiz you on things and ask you questions that are really in depth. What is the eosinophilic infiltrate? These questions, by the way, when people are answering in text, everybody's open to text what they are thinking and the answer choice they're thinking. So I see that we have E, and are you pretty confident with that? Would you give that a green or a red or a yellow? Green. Okay, let's do it. E, focal segmental glomerulosclerosis. So what do you think is causing the focal segmental glomerulosclerosis, real quick? It's okay if you don't know and you're just saying, look, I don't know what's causing it, but I know that it is FSG. But do you have an answer to that? You can say, I don't know. You got to give me idiopathic, maybe. Okay. All right. So green, let's see if it's the answer. All right. So we got toxic tubulointerstitial infiltrates. So this is a renal histology question. Whenever I see a renal histology question, I think about Pathoma and how amazingly useful that resource is. Obviously, I don't represent Pathoma. I don't make any money referencing resources. I'm just telling you about them and hoping that they are helpful if you get them. Obviously, I know they cost money, but Pathoma is an unbelievably useful resource. So what we're seeing here are these infiltrated. But let's see, that's not interstitial. So what is the illustration of? All right. So TIN, the answer is diffuse damage as well as eosinophils in the right upper center of the image. So let's see here. Right upper center. So here we go. Here. So the interstitium of the glomerulus, this is the glomerulus here. That's the parenchymal unit of the kidney is the nephron, and the filtration area, the largest filtration zone is the glomerulus, which has lots of arterial supply. And that's because it needs arterial supply in order to filter the blood, because it is basically, it's taking solutes and filtrates like creatinine and proteins and glucose, and it's deciding whether it wants to urinate them out and excrete them, or attempt to do that by allowing it further into the nephron, or if it would like to keep it in the blood, so to speak. And so, so let's see what the cause they say of this TIN is, which is toxic tubulointerstitial nephritis. NSAID-induced toxic tubular nephritis. So if we know that he's taking over-the-counter medications, we should assume, all things being equal, we should assume that it's an NSAID. That's a vague thing to say, but I think that's the case. It has to do with decreases prostaglandins. So one good question to the group is, as well as Sweta, is prostaglandins. What do prostaglandins do to the arterial supply to the glomerulus? So we have we have the blood that's coming to the glomerulus, and we have the blood that's leaving the glomerulus, right? Is it going to dilate or contract, and on which side of that process is it going to act? Is it the afferent or efferent um, arterial supply? Efferent, okay. So it actually, and are you saying it contracts or it dilates? Contracts. Okay. So I'm harping on a specific point that they didn't ask in this question, but actually the prostaglandins that NSAIDs block would otherwise dilate the afferent. And E for efferent is E for exit. And so that's the blood that's leaving the glomerulus. The blood that's coming to the glomerulus is afferent blood, and it's going to be you're going to get more blood if you're dilating, and so because you have less resistance. So the prostaglandins dilating that afferent arterial is what brings blood to the kidney and increases the renal perfusion pressure. When you have NSAIDs, you contract the afferent arterial because you don't really contract. You are dilating it less with your prostaglandins. And so you get less blood to the kidney. When you get less blood to the kidney, you potentially have toxic tubulointerstitial nephritis, which apparently will show interstitium that looks like this. This is caused from lack of blood flow as a result of prostaglandins no longer dilating the afferent arterial in the glomerulus. This is a really good point that's also explained using Pathoma very, very, very well. If you watch Pathoma and you don't understand this by the end of Pathoma, I think it is really a communicating, medical knowledge in a language problem. It is not his teaching, because his teaching is really, really good. I really don't know anyone who doesn't think that he explains the renal chapter well. It's that good. So I don't make money from Pathoma. I don't, but you'll learn that if you don't know already that a lot of American students rely on Pathoma, and they really like it. So thank you for answering those questions. It's like this is like the physiology of renal is really tricky. It can start out feeling very tricky, and I think it's very doable. But appreciate your answers, and we will get around to you again soon. So Rowenda, who's next in line, if we could, if I could ask here.
Yeah, sure. We can go back to Helen. Hi, Helen.
Has everybody gotten a chance yet? Have we done?
Yeah, I think Kelvin hasn't answered yet.
Kevin, are you here? Can you hear me? If you can tell the chat that you're here, I'll keep you in the group. Otherwise, I'll put you in the waiting room a little bit, because not because I want you to be in the waiting room and not learn, but because when I call on people, it wastes the time of the other people in the group. But Helen, would you like to read, or should I read?
Yeah, I can read.
Okay, great. All right, Kelvin. Okay. Oh, okay, understood. All right. Next time, we're going to want the functionality of the internet. It's one of the requirements that your internet works well enough that we can call on you, unfortunately, because you can always watch the video and learn from it. But I totally appreciate those things happen. So did you say you wanted to read, or should I? Sorry, Helen.
Yeah, I can read.
Okay, let's do it.
A thymidine kinase deficient varicella zoster virus strain has been isolated at a retirement home. Isolated retirement home. Many of the elderly has been infected with this strain and are experiencing shingles. Which of the following would be the most antiviral agent to treat this population?
Right.
Mm, I can guess. I don't know.
So shingles is caused by what? So it says varicella zoster virus. So what kind of virus is varicella zoster?
Mm, it's the RNA virus.
So it's a herpes virus.
Oh, yeah.
And so how do you treat herpes HSV1 and HSV2?
Mm,
You use so let's choose an answer choice because this is like a really rare question in USMLE where it's like you either know it or you don't because it tells you that it's varicella zoster. So it's not an obvious question, but it is a straightforward question in that they're just asking you, "Hey, do you know this?" And so there's not much to think about except that the thymidine kinase deficiency of the viral strain suggests that the mechanism of action of this drug would be implicated, and we'll talk about that a little bit. But which answer choice do you want to go with? And we'll choose a confidence, and then we'll talk about it. What are you thinking?
A. Canciclovir.
Famciclovir. Okay, okay. Which color do you want? Red, yellow, or green
Say-
here?
I'm saying A. A.
Oh, A, gancyclovir. Okay, okay. All right. And which color do you want here?
Red.
Red. Okay, yeah. That's okay. So gancyclovir is usually to do with CMV. So I almost never choose gamcyclovir unless we're talking about CMV. So if they tell you it's varicella zoster, you can't choose it because only by the virtue that it's not CMV. But this is cidofovir. So I think we caught a lot of people off guard with cidofovir because it would be very easy to choose acyclovir, I think. But some people said B. I don't think we saw a cidofovir answer. So this is going to be a good one for most people. So Helen, you don't have to feel like you're not in good company because I think most people did not choose this answer choice. But the mechanism of action of acyclovir resistance and production of viral thymidine kinase leads to decreased generation of acyclovir triphosphate. So that's a big, complicated way of saying that basically acyclovir works as a fake nucleotide for thymidine. And because it's pretending to be thymidine, that is a particularly high concentrated nucleotide within the viral species that is herpes viruses, including HSV1, HSV2, and herpes zoster, which causes chickenpox, what they call chickenpox in the States, which is a pediatric rash, usually pediatric, it can be in adults, that returns as something called shingles in your nervous system. And it's kind of like a unilateral, dermatomal distributed, painful / itchy rash that happens in adulthood. Usually don't see kids with shingles. It comes back later after you've had an infection of chickenpox. So I'm just throwing a bunch of facts out there because we're going to be on YouTube as well. You can access this information there. But cidofovir is the answer. So it does not require activation by viral thymidine kinase. So that's really the point, is that if you don't have viral thymidine kinase and you take acyclovir, the virus won't be converting the drug into its active form. So acyclovir needs to be activated by viral proteins. And so the side effects of acyclovir are limited to like crystallography in the kidney, because the other side effects don't happen because you don't actually have acyclovir effects until a viral thymidine is present. And if a viral thymidine is present, then acyclovir is being introduced to that cell and is acting upon the virus. So the side effect profile is very good for this drug as a result of this exact pathway. So that's the reason that they want you to understand it. Viral thymidine kinase is going to be an enzyme required to activate all of these drugs except for cidofovir. Amantidine's a little different, but cidofovir is going to be treating this disorder. Amantidine's not. So you can't choose amantadine anyway. And gamcyclovir is the same way. It's treating CMV. So that's a really good learning opportunity, I think. And these are really good questions. I think this session, if you were going to go over a session again, this would be the one, if you want to turn it up to like 2 times speed and watch this at 2 times speed and just go to the questions immediately. This is a good one to do it on because we have a bunch of really good questions and explanations here. They're saying 1 through 3 are all drugs that DNA polymerase inhibitors require activation of viral thymidine kinase. So this is a good thing to know. It's a detail that certainly they do test. Amantadine is used to treat influenza. This amantadine has to do with like you ever hear about flu H1N1? Those are H1 is how the virus gets into the cell and N1 is how the virus exits the cell. And so amantadine acts upon those pathways. And so it really has nothing to do with viral infections from herpes. But so that was a really good question, actually. So ordinarily, we would be making a ton of action points because I helped you guys get more questions right. But today, I let you guys just field your answers and then talked a whole hell of a lot about it. I think we got a lot out. I got a lot out of this session anyway. I hope you guys learned a lot. I'm gonna kill something real quick. Just show you I can pick things up by pressing D. I'm going to pick some items up, and I'm going to use some action points to show you what happens when we win a stage here. So I'm attacking the snake, and did I miss the snake? See, you miss snakes a lot with arrows and that's actually a feature of the game. It's very realistic. So if you're going to shoot an arrow at a snake, you better expect that you're going to miss it a lot because it's not a very big target. So we're going to hit F, and we're going to see that we got 2 out of 8, but that's because we were being very sincere about which answer choice we actually knew the answer was and not. But we completed 1 stage, we killed 2 monsters, and then you generate, the next stage, which is going to have stronger monsters and potentially have places that you can enter, different items. It's going to have different scenery, potentially different environments, different weather. And you're going to be able to read things and talk to people and learn where to go. And you're going to be able to play multiplayer. So let's say that I died, which I don't think I can commit suicide on this version of the game. But let's say that I died by quitting. And we go to game review. We can actually go to the game logs and see our most recent game that was 2 out of 8 here on this stage. And we can go straight back to this hepatitis C question. And we can identify, features of hepatitis B that suggest that this is a hepatitis C infection, that the RNA-dependent polymerase suggests that we should be taking sofosbuvir, and then you should also be taking a protease inhibitor like cimeprevir, which is something that you see in treating HIV. So this is a review. It will remember which things you highlight. You can go back to it at any time, and you remember that this is the game that I played in Archer, and I got to stage this. And so it helps you remember which quiz, in addition to all of the other things that it does, lowering your wanting to study threshold, allowing you to accountability from working with other people, allowing you to review answer choices and things like that. It also allows you to remember which questions you received on which day because you remember which character you played and how far you got and which items you had and things like that. So it's a nice tool. Really, strictly speaking, I feel like this is a tool, and it should be treated as such. It's a game, and it's going to be a lot more fun in a few months, but it is also a tremendous tool. I think eventually it's going to be. So I hope you can like, comment, and subscribe on the YouTube channel, and I hope you guys can go to some of our previous videos and like and comment and subscribe to the channel. It really helps us a lot, and it's kind of why we're doing so many sessions because I really like teaching. I would probably do it anyway, But I really love that you guys are participating. And thank you so much, AJ, for saying you think it's cool. I hope you play it a little bit. And if you guys ever get the inclination, on some occasions, we're going to be playing multiplayer. So if you talk to Rowenda and you'd like to join the multiplayer, stream and play multiplayer, nobody will see the questions that you're answering if you're playing multiplayer. They'll just see you on the map answering questions, and you can watch me while we're doing it. We can talk and think about the questions I'm answering. So thank you so much for joining us, and oh, thank you so much, Hema. I really appreciate that. I genuinely do, and I appreciate your input today. You've been very knowledgeable. I can tell you've been studying a lot of Step One stuff. So look forward to seeing you guys next week. And there's also, if you don't donate, if you never donate, it's totally fine. These sessions will remain free, but it does help us when you donate to the Ko-fi if you do have the means to do so. There's no pressure there. And looking forward to eventually coming out with the actual launch of the game. But it's free currently, so you can play it. Talk to you soon. Thank you so much. Let Rowenda know if you have any questions or if you'd like to feedback form as well. We'd love to get some feedback because then we can know what you guys really need to get you playing and using the game to good effect. So talk to you soon, and I'll see you next week. All right.
Thank you so much,
Rowenda as well.
everyone.
Yeah, thank Rowenda as well. Thank you.
Thank you. Bye.
Bye.